Welcome to the deep dive. You know how much we love taking these really specialized, complex topics and finding those critical nuggets, the memorable bits that tell the whole story?
Yeah.
Today, we're doing just that. We're peeling back the layers on skin replacement surgery, looking at the methods surgeons use to repair, well, the human body's largest organ.
It really is an area of medicine that sits, right between art and engineering.
Mm-hmm.
And when we talk about repair, it's not just patchwork.
Right,
It's regeneration.
right.
And that takes meticulous planning. We've sort of broken down the source material here to focus on three distinct pillars.
Okay.
There's the necessary surgical preparation, then the amazing advancements in autografts, and finally the rise of these really sophisticated skin substitute grafts.
And the sources make it really clear that every single step, from the moment the surgeon even looks at the wound, it's all governed by extreme precision.
Absolutely.
The whole approach depends entirely on what? The wound size, its location, and the type of material they choose for the repair.
That precision is, well, it's everything. It really determines the patient's outcome and also the resources needed.
Okay, let's unpack this then. Starting where every successful surgery really has to start, creating that perfect canvas. Let's talk surgical preparation. What's the fundamental purpose here? Why is it so critical?
Well, the foundational purpose is essentially to achieve a viable wound surface.
Viable, right?
Yeah, because you can't just put new living material onto dead tissue or infected tissue and, expect it to survive.
Makes sense.
So this preparation, it involves surgically excising, so cutting out non-viable tissue. That could be open wounds, maybe deeply scarred tissue, or something called burn Escher.
Wait, hang on. Burn Escher. For listeners who might not know that term, what exactly is that?
Oh, sure. Think of it as the thick, leathery, sort of dead layer of tissue that forms over a really severe burn.
Ah.
It actually stops healing and can encourage infection. So you absolutely have to remove that layer, often including the subcutaneous tissues underneath, just to expose healthy bleeding tissue. Right.
This prep might also involve, say, an incisional release if there's dense scar contracture that's limiting movement.
Okay, so this is definitely not just routine cleaning. The core difference here, and this sounds like a major administrative and medical distinction, is the intent behind it all.
Absolutely. The intent has to be documented. The surgeon is preparing this wound for a planned definitive closure.
A definitive close.
Yeah, that closure might be allowing the wound edges to be stitched together right away. So we call healing by primary intention.
Okay.
Or maybe more commonly in this context, preparing the site for, say, a graft or a flap, a skin substitute, maybe even that specialized vacuum therapy, NPWT.
So if the preparation isn't linked to one of those planned closures, it's something else entirely. Could you clarify that exclusion? Because that seems important.
Certainly. It's a key point. If a patient comes in with like a chronic wound, maybe a diabetic ulcer they've had for ages, or a venous ulcer.
And the surgeon just removes some dead tissue to clean it up, but the plan is simply to let it heal naturally over time, by secondary intention.
Just dressing changes in time.
Exactly. That activity is just classified as routine wound management. Our specific surgical preparation codes, the ones we're talking about, they are strictly reserved for those times when a significant planned reconstructive closure is happening immediately after.
Got it.
It's all about having that definitive repair plan locked in place.
That makes perfect sense. The plan really dictates the classification. Okay, now let's talk measurement, because the system seems to require this incredible mapping precision of the actual defect.
It really does. And the measurement is always based on the size of the recipient area, the hole you're trying to fill.
Not the skin you might harvest later.
No, not the donor site. It's the recipient area. The rules use specific size thresholds, sure, but the really fascinating part is this anatomical grouping structure. Yeah, the body's sort of divided into groups. For instance, the face and the hands might be in one group, while the trunk and most of the arms and legs are in another.
Okay, could you give us an example? How does that grouping work when you're calculating the total area?
Sure. Let's say a patient has two small wounds needing preparation, maybe 20 square centimeters on their right hand and 15 square centimeters on their left hand.
Okay, separate hands.
Right, two separate physical sites. But because both hands fall into that same anatomical group, you combine them. You'd report the total prepared area, which is 35 square centimeters, using just a single classification code.
So you're not coding two separate preps.
Exactly. The system aggregates those related sites. It helps capture the overall complexity and effort for that regional repair accurately.
Wow, okay. That consolidation rule really highlights the meticulousness needed. You're essentially treating, say, the hands as one surgical unit for this purpose. So, okay, the stage is set, we've cleaned the wound, mapped the site. The next big question is, what's the best repair material? Let's start with, I guess, the ideal option, the patient's own tissue, the autograft.
Yeah, autografts are definitely the gold standard. Why? Because there's zero risk of rejection.
Makes sense, it's their own body.
Right. And we usually categorize them based on thickness.
Right.
There's full thickness, split thickness, epidermal, and dermal grafts. In the traditional sense, this means harvesting a thin sheet of the patient's skin and basically moving it to the wound.
And the classification covers both steps, harvesting and applying.
Yes, typically the classification for these types of procedures inherently includes both the harvesting of that sheet and its application to the new site.
Okay, but here's where it gets, I think, really interesting based on the sources. The real game changer seems to be this skin cell suspension autograft, or SCSA. This is where biology starts to feel like high-tech manufacturing. How does SCSA just revolutionize using the patient's own tissue?
SCSA completely shifts the paradigm. You go from needing a relatively large piece of donor skin to needing only a tiny sample.
Tiny how?
Well, instead of transplanting a sheet, the surgeon harvests a very small, very shallow piece of epidermal and dermal skin. We're talking maybe 6 to 8 thousandths of an inch deep.
Wow.
The real magic, though, is in the preparation, turning that small tissue sample into a liquid suspension of cells.
Okay, describe that prep process, because the sources highlighted a very specific, almost mechanical step.
Yes, that specific step is manual mechanical disaggregation. It's quite interesting. First, the tissue gets treated with enzymes to sort of loosen the cells up.
Okay.
But then the surgeon, or maybe a technician, manually breaks down that skin sample into its basic component cells.
Manually, like physically breaking it apart.
Yeah, think of it less like blending and more like carefully teasing apart the tissues into this cellular soup, basically. That soup can then be filtered and sprayed onto the wound.
Like a biological paint almost, ready to be applied directly.
Precisely. It's applied right onto the recipient site and often onto the donor site too, actually. And that application process includes the primary dressings, and whatever fixation they use could be glue, sutures, maybe staples.
Okay, but why does this tech generate so much buzz? You mentioned needing less skin.
It all comes down to the yield, the expansion ratio.
Right, that ratio is astounding. Tell us about that again.
The expansion ratio of harvested skin to the prepared SCSA is typically 1 to 80.
1 to 80. Seriously.
Let that sink in for a moment.
Are we talking like a postage stamp-sized piece repairing a huge area? How is that even possible?
It is pretty astonishing. A sample of just 25 square centimeters, that's roughly the size of, say, the small address label,
Okay.
can produce enough viable cellular suspension to cover a massive defect, up to 2,000 square centimeters.
2,000?
Yeah.
From a 25, wow.
Yeah. The goal isn't just physical coverage, like a sheet graft. It's about delivering enough regenerative cells to the area. This drastically minimizes the damage to the donor site, which is huge.
I can imagine.
And it offers potentially life-saving options for patients with really large burn areas where finding enough donor skin is always a massive challenge.
That power, that ratio, it just represents a huge leap forward in reconstructive options, especially for those large area injuries. Okay, let's shift gears now to the third major category, skin substitute grafts. These come into play when, the patient maybe doesn't have enough healthy tissue to harvest, or perhaps the wound needs some kind of temporary structure.
Exactly. Skin substitute grafts represent those non-autologous solutions. So not the patient's own skin.
Non-autologous, meaning from somewhere else.
Right. And when we use this term, we need immediate clarity on the material source. You might hear about allografts that's skin donated from another human.
Okay.
Or xenografts that's material derived from an animal source, like porcine skin.
Right, pig skin often.
Yeah. Or, alternatively, they could be purely biological products, engineered in a lab, synthetic or biosynthetic.
And the common thread is that they all form a kind of sheet scaffolding for skin growth. Is that right?
That's exactly it. They are designed to act as a temporary matrix, or scaffold. They provide structure that the patient's own underlying tissue and, importantly, blood vessels can grow into.
Ah, okay. Integration is key.
Yes, and this is why the specific codes for these procedures are not used for just simple non-graft wound dressings, things like gels, powders, liquids.
Things that just cover the wound.
Right. If it's not forming a sheet-like scaffold that encourages tissue integration, it's generally not classified as a substitute graft in this context.
That distinction, structural scaffolding versus just a covering, that seems really key. There's also a crucial administrative step here, isn't there, regarding the material itself, separate from the procedure?
Yes, this is a critical point, especially for hospitals and clinics managing inventory and billing. The application procedure, the surgeon's time and skill preparing and placing the substitute, that's classified distinctly from the supply of the material itself.
Ah, so two separate things to account for.
Absolutely. The supply of the graft material must be reported separately. This allows for really precise inventory management, which is vital because these biological products can be quite expensive and are often highly regulated.
Makes sense. And when you actually code the application of these substitutes, you go back to that same rigorous system of grouping and measuring we saw with the surgical prep phase.
We do, yeah. It's very similar. Application procedures are selected first based on the anatomical location. So, trunk extremities versus face digits, just like preparation. But then they add another layer, the total wound surface area. So the system creates this kind of multi-layered matrix. The surgeon has to map the wound to the right anatomical group, add up the total size if there are multiple wounds in that group, and then select the specific classification that corresponds to that surface area threshold.
Like under or over a certain size.
Exactly.
Right.
For example, there are different codes for applications up to 100 square centimeters versus those greater than or equal to 100 square centimeters.
It's just a remarkable system of checks and balances, really, making sure every variable gets accounted for. We've definitely covered a wide and frankly amazing range of techniques today. Everything from that essential first step, the surgical prep, all the way to deploying these advanced biological materials, whether it's the patient's own tissue amplified via SCSA or these non-autologous skin substitutes.
I think the big takeaway here is that the true complexity in modern skin replacement surgery isn't just in the skillful surgical technique itself, though that's obviously paramount.
Right.
It's also in the incredibly meticulous classification that has to happen before and during the procedure. That detailed definition of the wound site, its size, the depth of tissue involved, and the exact origin and type of the repair material being used.
Every single one is a critical variable.
Yes, each one fundamentally changes the nature of the repair and how it's understood systemically.
So what does this all mean? I guess it means that repairing the body's largest organ requires this remarkably precise, segmented approach, where the preparation, that initial step, is really every bit as important as the sophisticated material you end up applying.
Couldn't agree more. And maybe let's end with a final provocative thought for you, for the listeners. Considering that incredible 1:80 expansion ratio we talked about with the skin cell suspension autograft,
Yeah.
just imagine the future implications of that. How will our ability to regenerate vast areas of the body from just a minute tissue sample fundamentally change how we respond to things like global disaster medicine or large-scale traumatic injury scenarios? It's pushing beyond just repair. It's really pushing the boundary of regeneration itself.
A powerful future to consider indeed. Thanks for joining us on this deep dive into surgical precision and regeneration.